Is the Department of Internal Medicine grand rounds for today, which is Thursday, October 31st, 2024. Thank you guys so much for attending. We are currently holding our grand rounds in the Molecular Medicine Research Building, which is in rooms 1009, 1011, and it's located on 1220 East Broad Street, right downtown in the heart of Richmond. So thank you so much for attending. We also have a dedicated Zoom link for those who are joining us virtually. So as you can see, the QR code is available for those who want to get credit. It will also be posted at the end of the lecture for several minutes for those who come in late. So today our lecture will be sponsored by the Division of Infectious Diseases and will be presented by the Chief of Infectious Diseases, Dr. Gonzalo Bearman. Dr. Bearman is the Chief of Division of Infectious Diseases, Richard P. Wenzel Professor of Internal Medicine, and Associate Chief Quality and Safety Officer for Research at the VCU Health Systems. His primary clinical focus includes general infectious diseases and HIV care. Beginning in 2005, Dr. Bearman has led the VCU Global Health Program through the Honduras Medical Relief Brigade, a medical relief effort bringing medical and public health assistance to rural Honduras communities. His area of administration and research focus on the epidemiology and hospital-acquired infections. Dr. Bearman has various industry grants and has published over 200 peer-reviewed publications, multiple editorships of books, and is the primary editor of 3 medical textbooks. In 2013, Dr. Bearman founded and is the editor-in-chief of the Medical Literary Messenger, a literary magazine with a focus on medicine and humanism. Dr. Bearman previously served as the chair of the Society for Healthcare Epidemiology of America Guidelines Committee and was a member of the FSHEA Board of Trustees. In 2023, Dr. Bearman received the Society for Healthcare Epidemiology of America Career Mentorship Award, presented at ID Week in 2023, the annual meeting in Boston, Massachusetts. In 2019, Dr. Bearman also received the Society for Healthcare Epidemiology of America Barry Farr Award for the most influential publication in infection prevention and hospital epidemiology. Presented at ID Week 2019, annual meeting, Washington, D.C. in October of 2019. Other honors include the VCU School of Medicine Educational Innovation Award in 2014, the VCU Medical Shining Knight Honor Award in 2016, the Virginia Living Magazine Top Doctors Infectious Diseases, which was awarded in 2018. The Richmond Magazine Best Doctors in Richmond for Infectious Diseases for 2011 through 2020. And in 2020, Dr. Bearman received the VCU Department of Medicine Excellence and Scholarship Award. In 2023, Dr. Bearman also received the FSHEA Career Mentorship National Award. Most recently, Dr. Bearman has led critical efforts to address the COVID-19 pandemic on research, clinical, and operation fronts. He has assumed various roles for VCU Health, including VCU Medical Center, Incident Command Center, Infectious Diseases, and Hospital Infection Prevention COVID Program for COVID-19, Director, Co-Investigator in Remdesivir and Sarilumab clinical trials, Primary Investigator for VCU VDH COVID-19 Seroprevalence Study, which was a $100,000 grant, Co-Senior Investigator for VCU COVID-19 Healthcare Worker Seroprevalence Study, which is VCU School of Medicine and VCU Health funded. His primary media respondent for VCU Health on COVID-19 for internal and external media requests, the member of the Virginia Disaster Management Advisory Committee to Virginia Secretary of Health and Human Services, and infectious diseases consultant, and a member of the VCU Public Health Response Committee for University Reopen. as well as infectious diseases medical advisor to VCU Athletics for COVID-19, and infectious diseases medical advisor to the A10 Advisory Committee for NCAA Division I Athletics. Since 2021, Dr. Bearman is editor-in-chief of Antimicrobial Stewardship and Healthcare Epidemiology of the Society for Healthcare for Epidemiology of America, published by Cambridge University Press. Please help me in extending a warm welcome to Dr. Gonzalo Bearman.
Okay. Yes, sir.
Who knows how good a drummer he is?
All right, team guy. All right, well, thank you so much, Karen, for that very nice introduction. And thanks, Todd, for those comments. It's a huge pleasure to be in such a friendly crowd. I've given this lecture a couple of times already at the University of Colorado and Brigham and Women's Hospital, Harvard University. So it's nice to be in my home turf to discuss this topic. Now, I have two names on the primary slide. This is because the lecture is co-written by my colleague, as well as the manuscript that corresponds. My colleague, Dr. Priya Nori, is an associate professor of medicine and orthopedics at Einstein College of Medicine. So let's set the tone with the disclosures. I have no relevant disclosures for this. The learning objectives are to define compensated versus uncompensated work in academic medicine, understand individual, institutional, and team factors that determine high value versus low value tasks. Number 3 is practice using the value compensation matrix and apply it to everyday scenarios. So I'll give you some examples, at least from the infectious disease world. You can probably translate that into other medical specialties. And then last but not least, apply the 6-step program to maximize high value and minimize low value tasks to meet your immediate and long-term goals. We're frozen. There you go. So to set the tone with a quote here, don't count the days, make the days count. So really to be really deliberate about what you do on a day-to-day basis and have as much control of your schedule as possible. So step 1 is define highest value priorities and take inventory of uncompensated work and distractors. I'll ask a question to the audience. So you don't necessarily need to respond, but just keep this in mind. How many of you have actually stopped and paused to take inventory of the uncompensated things that you're doing on a daily or weekly basis? If you haven't, you should. So what is important to us? I want to make a comment that I think is under discussed, okay? And this is in the literature of vocational behavior, in the journal of vocational behavior and the literature of really business. It's the best meta-analysis that I could find is a relationship between pay and job satisfaction. A meta-analysis of the literature published in 2010. So it's a little dated, but I haven't found a newer one. And they looked at 115 correlations from 92 independent samples for pay level. And it's quite astounding, guys, that pay level correlates only 0.15, or you would say 15%, with job satisfaction, and only 0.23 or 23% with your pay satisfaction. And the take-home message here is that pay is not the primary motivator for knowledge workers. And everyone here, by the way, is a knowledge worker, okay? So if that's the case, let's just argue also, you want to get paid enough. You don't want to get paid a pauper salary after having many years of education and doing high value knowledge work, but you want to get paid what you feel is fair and adequate and enough, at least, right? So what motivates us most? So let's look into that. And if you haven't had the opportunity to read a book, I encourage you to do so. This book is called Drive by Daniel Pink, and the subtitle is The Surprising Truth About What Motivates Us. Now, I realize we're all very busy, okay? So if you don't have time to read this 200, 300-page book, you can watch the 18-minute TED Talk by the author, okay? And he'll give you everything you need to know about the book. And what he essentially boils this down to is that knowledge workers, which is all of you, are driven by 3 things: mastery, autonomy, and purpose. So think about that in your line of work: your mastery, your autonomy, and your purpose. Now, I'm going to quote a good friend of mine, Mike Edmond. Now, this is infectious disease related, but it may translate to those other medical specialties, particularly the Department of Medicine. This is a careers article, a question and answer that was published by Mike Edmond. Title is Mike Edmond on the Value of Change, Learning, and Pay Close Attention on this component, and not letting others set the agenda. So he says, or he writes, ID specialists, let's just say internists, how about that, are very hardworking, effective, but most comfortable working away from the spotlight and don't take credit for their good work. We've not been effective in setting our own agenda. And that's really important, relevant to this discussion. Because what I'm going to tell you in the remaining steps is not what the institution can do for you, but what you can do for yourselves, which is very different. It's a perspective on you and what you think is important. So with that, we're going to go back to another book reference. Start with Why by Simon Sinek. Who's seen or read this book? A couple of people out there? Rebecca? Okay, a couple of you. Phenomenal book. Again, if you don't have time to read the book, take the 18 minutes, 30 seconds to watch the TED Talk. It's one of the most visited and frequently seen TED Talks ever. And it's about 10 years old now, maybe a little bit longer, but I think it's still very relevant. And it start with why, how great leaders inspire everyone to take action. And what really comes down here is that you have to ask why you're doing what you're doing. You have to be very deliberate because this should set the intent for everything that you do, at the very least professionally. Have a clear understanding. If you don't have an elevator pitch as to why you're doing what you're doing, you better rethink that. So let's look forward to that. So what are your top professional priorities? So I have my priorities, and I have that of Dr. Norrie's, which she put in this presentation. So my top 3 priorities are leadership and mentorship as the infectious disease chief. And you know what? That's compensated. Patient care, that's compensated too. Academics and scholarship, hugely important to me. Those close to me and the ID team know I talk about this all the time. They're probably sick of hearing it. It's partially compensated. I have grants, I have an editorship that's paid, et cetera, et cetera. Okay? Dr. Norrie's top 3 priorities are patient care and stewardship, which is compensated. She's really into mentorship, formal mentorship of faculty members and students and residents. She notes it's uncompensated. And there's academic/scholarship, which in her opinion is uncompensated for her. So any requests that fall outside of your top 3 priorities must be scrutinized and reconsidered or rejected. So let's explore that a little bit more. Step number 2 is to budget no more than 20% overall effort for uncompensated work, especially if low value. Now, let's be very clear. This is a truism, and I don't think anyone can challenge me on this. When you work in a major organization, they're going to ask you to do uncompensated things. Is that correct, Dr. Fowler? You've been here a long time. Dr. Gear, do you agree with me? Absolutely. You're going to get asked to do uncompensated things. So you're going to get asked, and the number of asks is going to be huge. So be aware of that. So how do we get to this 20% work? Well, let's defining clinical effort in academic medicine. Believe it or not, this is quite astounding to many people, but if you delve into this literature and you're involved in professional societies, there's actually no published definition for what a 1.0 clinical FTE is supposed to do in an academic medical center. There's no published definition. So it's defined by how it's defined for you and how you let others define it for you. Effort estimation varies across academic centers. It's based on research funding, clinical needs, et cetera, et cetera. Clinical and research funding contribute to varied amounts to non-funded activities such as teaching. And we argue here that individuals should not exceed 20% effort in unfunded work. And we're going to get to this in a little greater detail in a second. With that, academic physicians should set limits based on the fraction of compensated and uncompensated work. You need to take that inventory. So I'll bring you to this article here that was published. It's out online. I found it online, and it's Burnout in Academic Physicians. And you're probably not going to be surprised. Well, you all know that there's a significant degree of burnout in academic medicine, correct? Probably private medicine too. That these, in this review articles, the authors summarize that there's higher risk of burnout observed in faculty involved in a higher percentage of what? Uncompensated roles. So let's explore that a little further. But before we get to that, I have to make an important admission here. This is really, really important. And this is really brought out to me from my colleague, Dr. Norrie, is that there are unequal expectations on all of us. These are 2 things that I can't speak in first person, but I've learned about, and I've heard about, and I've read about. That not all of us have the same stressors or expectations. For example, there's a paper out there in Time magazine called The Secret Tax on Women's Time. It's referred to as the pink tax. So if you're a woman in academic medicine as a physician, and you also have children at home, for example, many feel, or many are expected to still have that role in the home, in the household, to manage the household, while still being a full-time doctor and being academic and getting promoted, et cetera, et cetera. But it doesn't just stop there. There's also a minority tax, and this was published in the New England Journal of Medicine not too long ago. The minority tax is avoiding overtaxing the minorities when we need them the most. The most immediate example that comes to mind is forming a DEI committee and tapping, let's say, your Black and brown colleagues to be in the DEI committee or to lead that, which is probably a noble and just cause, but they're probably not compensated for that, and their clinical effort isn't adjusted to accommodate the time required to do that properly. So there are unequal expectations, and this further increases the stress. So what's the leadership goal? There's a very cool paper that was published in 2017. Encourage you to check it out, but I'll give you the summary. This is from Tate Shanafelt and I in the Mayo Clinic Proceedings. And it's really recognizing the unique talents of the members of the team. So that sounds a little corporate, so I'll give you some more detail. Essentially, the summary of the evidence suggests that healthcare workers who spend at least 20%, not 30%, not 50, not 100%, 20% of their professional effort focused on dimension of work they find most meaningful are at a significantly lower risk for burnout. We're talking like 60% less. So think about that. Define what's important to you. What gives you some degree of joy in your job? Do you have appropriate time allocated to that? And it doesn't always have to be the compensated stuff. We'll get to that in a moment too. So this may look different to each of us, includes teaching, mentoring, writing, et cetera, et cetera. I very much enjoy seeing patients, but those that know me or close to me know that I really like reading and writing manuscripts. That is a lot of fun for me. It'd be fun for you, but that is what's fun for me. I have the time to do that. So since essentially in the dangers is that we don't recognize and we allow us to do low value, uncompensated work. This is something that we published in Clinical Infectious Disease. The examples that come immediately to mind for infectious disease doctors, this may be for the other specialties too, it's the classic curbside consultations, participation in hospital committees outside of professional interests, or other, quote, citizenship tasks. I'm sure you can think of some of those, are important threats to our valuable time as ID providers or internal medicine providers. And once again, we need to establish our own agendas and reclaim our professional autonomy. So we must set boundaries. So let's move on. Let's go to step 3. We must protect and focus non-clinical or uncompensated time. So what is uncompensated work? Well, this is really important. If we're going to say don't do more than 20% uncompensated work, it is up to you as members of the medical teams of the medical community here at VCU Health to define what's high and low value. Now, I'm going to give you my definition of high and low value, but that's not necessarily yours. But I will tell you, much of what I write as high value here is consistent with institutional goals, particularly if you're a faculty member in the institution and you seek promotion and tenure. So for high value would be things that are for promotion and tenure, writing abstracts, for example, grants, manuscripts, or book chapters. You're being teaching portfolio specific, like mentoring learners, doing things with ID fellowship lectures or journal clubs, that's for our subspecialty, teaching at the bedside, residency program and medical school lectures, internal medicine presentations, such as internal medicine grand rounds, that's considered high value, and being involved in professional societies, whether it's committees, guidelines, or writing groups, that's very high value if you're seeking to advance your professional career. Now, at the risk of making some enemies, I'm not the most popular guy, so I'm not so worried about it, but there's a lot of uncompensated work. And this is my brief, but not exhaustive or overall summary, not complete summary of low value of questionable, unproven benefit for advancement. Number 1 is ad hoc medical committees from the hospital. Number 2 is ad hoc med school committees or one-off requests. Now, if your job and your role is to be a medical educator and you want to be in the School of Medicine, in the dean's office, et cetera, I would say go for it. That's perfect for you. Okay. Ad hoc requests for resident morning reports appearances. No disrespect to our residents, it's generally not considered a high value academic endeavor by the School of Medicine. Advising student interest groups. Again, no disrespect to the School of Medicine. Again, not considered a high value academic measure when you're looking at promotion and tenure. Okay. I'm not saying don't do these. Commit to them if that's of interest to you, or commit to them sparingly, or do them once a year, and that's cool, but don't make yourself available all the time. Okay. Almost any health system task force, I can speak from a lot of experience, I've been here 22 years. Most health system task forces go nowhere. Is that right, Dr. Dahl? No comment, okay. Online training modules, okay, we can't do much about it, but I wouldn't say that's there. Double thumbs down on that one, okay. Anything in the name of citizenship? Well, when I say by that, it's like really be careful what you're you're agreeing to do, particularly if it's not aligned with what you think is valuable or what your team thinks is valuable or what you think may promote you or get you promoted. Again, all of these things are reasonable things to do, but you have to be mindful if you're going to do them, what are you not going to do to accommodate? And that's really important. Okay. So step 4, clinical care. Now, this is getting to the providers in the room, and this is really important. So it's going to focus on minimizing electronic distractions and leveraging support systems really to maximize your focus. I know you guys have heard it all before, but there's a real problem with distraction in the modern era. This is a very cool book I would encourage you to check out, titled Deep Work, Rules for Focused Success in a Distracted World by Cal Newport, Georgetown University, I think associate or full professor now. Unfortunately, guys, there is no TED Talk on this one. Okay. So you can take my word for it and check it out yourself. I got a copy in my office. You can borrow it. I do want it back. Okay. So what he argues is that efforts to deepen your focus will struggle if you don't simultaneously wean your mind from a dependence on distraction. Who here feels that they're overly distracted during the day? Anyone want to admit to that? Most of you. Okay. I used to feel that way, but I'm less and less distracted. I will tell you what's worked for me. It may or may not work for you. But note that these are important threats to our valuable time. Number 1, emails. Hugely threatening to your valuable time. Number 2, epic chats or similar EMR charts. Most of these are not urgent, but people are distracting you to get their question answered at that time because they can't wait for the consult team to come around, or they can't wait till they see you later in the break room, et cetera, et cetera. Inconsistent schedules and ad hoc meetings, inadequate clinical patient care support. You can all argue we need more PAR supports, et cetera, et cetera. And then low value uncompensated work is also a big distractor. So let's explore this a little further. So we're constantly bombarded with external distractions, and I would argue it has consequences. In fact, going back to a very cool article, this is one I encourage you to check out. You should all have access to this as VCU faculty and staff. The title is Email Making Professors Stupid? It is used to simplify a crucial task. Now it's strangling scholars' ability to think. This is pretty recent. This is like a year or 2 ago, and it was published in the Chronicle Higher Education, which is nothing to sneeze at. It's a very high-level journal in academics. The argument here is that email has become a kind of a digital water torture for the scholar struggling to think without interruption. You know, I know they focus on scholars, but why not the physician or the healthcare provider or the PA, et cetera, et cetera. We must use email deliberately. Here it is, not be used by email. So going back to a book by Cal Newport, again, no TED Talk, great book. It's on my shelf. You're welcome to borrow it. It's titled A World Without Email, Reimagining Work in an Age of Communication Overload. This is not necessarily a thought experiment. He actually gives you a lot of cool examples. He argues that while email use certainly saves people time and effort in communicating, it also comes at a huge cost. Now, I've learned something over the years with email. If you open up your inbox first thing in the morning and or through the day all the time, it becomes a live chat. You guys seen that? So figure out when you want to answer your emails and do so because they're never an emergency. Here's another thing I've learned. Emails with many things in life, the more you give, the more you get. So I send out as few as possible, and then I get few responses. So think about that. So our suggestions: turn off all email and social media alerts. That was like an easy fix I made years ago. Just turn off that little thing that pops up or the dinging sound so I don't hear any of these alerts, and that's really helpful. I do batch my emails. I actually do them at select times in the day. I usually start answering, here's my trick, around 3:30 or 4 p.m. Notice that the problems that were raised earlier in the day are usually solved by the time I get to them, or when I answer, the people that I've sent the answers to have pieced out and are gone. So I don't get another response till the following day, if at all, and they probably moved on to something else by then anyway. So use email succinctly. Now, who here opens up an email and sees this much text and decides to actually read it? Anyone? Okay, so good. You're all part of the people in the know, it seems here. Use email deliberately and succinctly. So I'm going to present another book to you that I would suggest you check out. It's called Smart Brevity, The Power of Saying More with Less. This is a very short book, by the way, as you would expect. Very short, okay? Again, it's on my desk. I think it's on my desk. If you want to borrow it, you can borrow it. I want it back. So the arguments are that write, then go back and kill at least half the words. It winds up sharper every time. I would say whatever you send me, cut it by 90%, and it's probably right, okay? Keep messages to 5 lines or less, absolutely. Use email for brief targeted information sharing. Be deliberate with messages and recipients. I get copied on so many emails, I'm not even sure why I'm being copied, or people put me in, like ask a question, I'm like, is this to me or the 10 other people that you put on the recipient line? Because I have no idea, okay? Beware of those excessive CCs. Think about that today when you answer your emails. Cut out the CCs as much as possible. And avoid, this is probably the most important, avoid sending emails in an emotional state. If I get an emotional email, and I don't get them too often, I don't respond to them. Rule of thumb, I will not respond to that. Avoid important conversations via email to the extent possible. Remember, email is rarely for important decision-making. It's really for information. But this brings me to this next point. And this is an a post on Twitter, I guess now X, by a doctor, I think from George Washington University or something like that. And he writes that Epic Chat, well, I'm saying Epic Chat is a major distractor. People that know me know that I hate Epic Chat, and I put myself permanently offline on that, by the way. I know it's not popular, but I just don't do Epic Chat. The volume and frequency of distractions in modern medicine has created a stressful work environment. True. My chart messages, Epic Chat, emails, texts, pages, etc. It's out of control. Can't talk with patient or colleagues or think without a distraction. This culture's got to change. Got a lot of views and a lot of reposts. So really the underlying theme here is to turn off or silence your Epic Chats. Now you don't necessarily have to turn it off permanently like I did, but you can open it up deliberately and look at it when you're ready. It doesn't have to be live and open and pinging all the time, especially in times when you require maximal focus. You know those 4 hours you're in the clinic? Probably the best time to turn it off. You know when you're doing rounds with your academic team for about an hour and a half or 2 hours, turn it off. It's not relevant, okay? Case conferences, patient rounds, internal medicine grand rounds, you shouldn't be answering your Epic Chats right now. Okay. Things are never that urgent, and you're under no contractual obligation to respond immediately to any of these messages. That is true. That's absolutely true. You're under no contractual obligation to do that. So think about that. In terms of other things to consider, there's a lot of information out there on the internet and the published and published. Consider some efficiency in patient care matters that I would encourage you to at least explore if you've not done it already. You know, leverage your support staff. I've known many young doctors who don't ask for support staff to help them with prior authorizations, Epic message responses, at least the preliminary responses, obtaining old records. Why are you calling that office yourself? You have an entire team to get that for you. Have them do it for you, okay? Learn EMR charting, shortcuts, and templates. I've done that. I've met with the chief informatics officer. He gave me some tips, hugely helpful. Being mindful about phone calls and family conferences. Use them sparingly. These will eat up a lot of time. I'm not saying don't speak to family, it's just be mindful of the timing and the appropriateness of when you're going to do that. And stay focused during the visits, minimize your distractions. So we're moving on. We're going to go to step 5, which is prioritize an individual response to uncompensated work while honoring group needs as a team player. So this is really important. Really what I've been talking about now is what you can do to make things better for you, your flow, your focus, et cetera, et cetera. It almost sounds like every person for their own, every man for himself, that kind of stuff. And that's not really what I'm trying to say here. I'm trying to say that you want to be focused, but you also have to understand what your group goals are to do this in such a way that you're still a team player. So those that know me know that I'm obsessed with, I guess, a couple of things. One of them is soccer, and the other is drumming. Thank you, Todd. I don't have any drumming references, so that's coming one of these days. And I did like the show Ted Lasso a lot. So I'm going to use a quote from Ted Lasso, and he says to Jamie, he says, Jamie, I think that you might be so sure that you're 1 in a million that sometimes you forget that out there you're just 1 of 11. And if you just figure out some way to turn that me into us, the sky's the limit for you. So be a team player. And that's not just in the Ted Lasso literature, so to speak, okay? There's actually a cool paper that was published in 1999. So I was chief resident in 1999, just finishing my chief residency. It's been a while. And I did not come across this paper. In fact, this paper was given to me by Dr. Wally Smith, who's still here at VCU. And it's titled Simone's Maxims, Understanding Academic Medical Standards. And he has various maxims or truths that he's observed over the years. One of the maxims I like the most is this one. Personal attitude and team compatibility is grossly underrated in faculty recruiting. The idea is you always recruit the best athlete or the best scientist or the best chief resident, et cetera, et cetera. But that's an oversimplification because they have to be part of a team, right? So A faculty member may be productive personally, but create an atmosphere that reduces the productivity of everyone else, or simply does not collaborate with others in academic or clinical endeavors. So this is my experience in the text box, is that rifts and rancor will appear when an individual is perceived as not a team player. I'm happy to say there are no non-team players in the ID division of ECU, because people are long gone. So how do you make that team ethos explicit? Now, I don't have the answer. I can just tell you what we did at VCU. We actually published this in a paper in February 2024. As part of the paper I'm referring to here, is we as a team collectively decided we're going to have our basically team rules. And our team rules are kind of simple. It's the ID division is dedicated to excellence in all matters, not research versus clinical versus teaching. Just all of our mission, we're trying to be as excellent as possible and work with the well-being of our faculty in mind, and also the fellows and the staff through the core values of being collegial, collaborating with each other, being inclusive of each other, being transparent, showing gratitude, and going for work-life flexibility. We did not say balance, because that's pretty hard to do. Some days are more balanced or imbalanced than others. We just want to be as flexible and support each other. So you got to have a team ethos. Number 6 is call your sponsor before taking on any additional work and appraise it using the value compensation matrix. So this is a 6-step program. The AA program is a 12-step program. This is shorter, 6 steps. Your last step in AA is you call your sponsor, right? Or you got to call your sponsor in step 6 here. So the ask from the suit, so I'll give you some example, as a member of the ID division practice is needed to, these are common ones, develop and implement a preparedness plan. Sound familiar? Yes? Okay. Lead sepsis committees. Does that sound familiar? Yes? No one wants to nod. Okay. Serve as an ID liaison to the hospital DEI committee. Take over the medical school ID/microbiology course. We've heard that before. Develop an ID telemedicine service. That sounds familiar too. Develop an OPAT or an OPAT team to reduce readmissions to the IDU population, et cetera, et cetera. So these are common asks. So think about that for a second. FYI, no effort or compensation allocation for now is given to you, but maybe in the future, dangling a carrot, right? Depending on duration of needs and priorities of the organization. Sounds like common language, right? You're laughing, fine. Yeah, okay. So recall step 5, the needs of the team division. Somehow this ask must get done. So the question then becomes is, what are internal and external incentives and drivers, and how are these in our favor? Well, remember, we have some drivers that we can't fully ignore, or some RVU benchmarks. We also have achieving financial health and independence, academic promotion and hospital leadership roles are there. And then of course, citizenship, which is credibility and trust among colleagues and hospital leaders, being helpful and available. So these are things that are kind of in the mix that you need to think about, right? So what are the unique challenges and threats to our well-being as academic physicians? You have to think in the daily and the long term, the internal, which is within the healthcare system versus external. This is important, team. What's within our control and what's external to our control, because that's going to guide the decisions we're going to make shortly. And how much should we tolerate versus speak up against? Example, daily grievances versus a workplace injustice. What do our values dictate? These are important questions that you need to explore when you're looking to take on additional tasks. But that gets us to this important question: what does a professional sponsor look like? I will argue right now, it does not need to be the division chief. It does not need to be your division chief or your department chair, okay? It should be someone in a supervisor role, but who has your best interest in mind. It could just be a doctor that's a little more senior than you, that you get on well with. It doesn't have to be within your division, so to speak. Your success should be viewed as their success, particularly if they're working together as a mentor, not as a threat or a competitor for the same opportunities. Internal examples, I've given some already, but there are the clinical director, the division chief, research or academic mentor. Look for your mentors. And by the way, team, your mentors don't always have to be more senior than you, right? There's vertical mentors, the ones who are more senior, and there's the horizontal lateral ones, right? The ones that are kind of in your class. Now, when I was in college, I distinctly remember the first year I was playing college soccer, the coach said, find out who's killing it in your chemistry class and go hang out with that guy. That was the recommendation that was given. It sounds a little sexy, just talking about hanging out with a man only, et cetera, because that could only be the successful one. That's not what's really meant by that comment. But the point is that you can find people that are very successful around you, maybe at the same level, maybe same rank, that can give you some clues on how to be successful, okay? And then you can also look at external examples, or such as peer mentors, people who you trained with now at other institutions, committee members, or even friends within the professional societies. I do want to put a plug in for your professional societies, whether it's an ID society or a cardiology society or nephrology society. Those are great resources to learn from your peers and learn from their experiences in other institutions that can guide your roles and your choices in your own institution. So what are the questions to discuss with your sponsor? Well, what are your highest value professional priorities? Now, I have mentorship sessions with my team a couple times a year. Individuals, I ask them, what do they value about their jobs? What's your priorities? If you can't really articulate that, you got to go back and think about it, okay? Number two, how much effort is required for this new task that you're taking? If you're being asked to do something, how many hours is it? A realistic effort. And think how you spend your work, or you would spend your work week, and how will you budget no more than 20% of your work effort for this new uncompensated work? So make that budget, and if you're adding something to it, take something away. How will you protect and focus your non-clinical admin time to get the task done? These are important questions. How will you minimize electronic distractions to make you efficient? We talked about that already. How do these align with your goals and with the divisional team needs? Now, I'll briefly talk about something that would be essentially uncompensated work, but it's important for infectious disease, and that's our academic mission. Dr. Jillian Raybould, who's our fellowship director, came up with a really cool plan known as the EVUs. Did I say that right? EVUs? You guys have all heard of RVUs, right? This is EVU, Educational Value Units. So we have a certain need, fellows, clinics, certain core lectures to our fellows, internal medicine, ID, case conferences, et cetera, manuscripts, abstracts, et cetera. And those are assigned an educational value unit. And we parse them out as equally as possible across the group. So you have to meet the needs of the team, and some of that will be uncompensated, but it could be good not only for the team, but also for your promotion. Okay. How will you turn current uncompensated work into an eventual effort or compensation? So if you're launching into something and there's a carrot dangled, have a plan on how you would make that compelling later on to have it financed for you. And here's the most important thing at the end. How will you politely but clearly say no? Does anyone ever practice saying no? Laura has. Do you want to give us an example? No is a complete sentence for Dr. Laura Peterson. Yeah.
Thank you for the offer.
Okay, thank you for the offer, but I cannot take this on right now. Okay, fair enough. Usually when that happens, they get the message. The example I'll give you is, you don't mean to sound disingenuous and pick on any particular group, but I'll just give you an example that was recent. We got ourselves out of this. Our division no longer has a representative for the, I don't know what they call it, like epic updates, or I don't know what we call it. Division is supposed to have someone, an epic liaison, let's call it that. It's not particularly interesting to anyone in our group, or we stopped doing it. If there's a critical update, I guess we'll hear about it. Now, I'm not trying to be sarcastic, and I'm really not taking a swipe at Epic. It's an important medical record, and it's part of our daily lives, but we can't do everything at all times, and there was just no time for it. Okay? Should we have an opportunity to revisit that, I'm sure we can rethink about it, but right now there was no one interested in that, and that's certainly not anyone in our group is interested in medical informatics as a career path. It's a very legitimate career path, I might add, very legitimate. Okay. So consider the value versus compensation conceptual approach. All right, guys, if you're going to remember anything, remember this figure. It's simple. So you've got on one side, on one axis, compensation, the other is academic or personal value. And you can see the grid. You've seen these 4x4 grids, haven't you? So something is low compensation, low value, I suggest you avoid it. If it's high compensation, low value, consider. It may be boring, but it pays you well. It's one of those situations. If it's high value, low compensation, consider. I would put a lot of things that we do as high value, low compensation if you're looking at it from your academic growth and professional growth. It's two things, academic and professional growth. If it's high value, high compensation, I would say that's ideal. I mean, definitely go for it. Okay, so that's the value compensation matrix. So how should you do it? Consider your motivations for saying yes. Elaborate on values. How does this task fit with your personal values? Be clear about that. How would saying yes help the team or the division? Are you a team player? My sense is you probably are. How would you politely decline tasks that do not align to keep the door open for future or better opportunities? Okay, so I'm not available now, but I think what you're telling me is very important. Could we revisit in 6 months or a year or whatever, 2 weeks, whatever's important to you there? What if the task is high value but uncompensated? What's your plan to turn this into effort or compensation in the future? And last, how can you offload current tasks to take this on? So these are important critical questions you should be asking yourself or working with your mentor to figure out, do I do this? Do I not? Do I do it now? Do I do it later? Or do I never do it? Okay. So the summary of the 6-step program is: number 1, define the highest value professional priorities. Take inventory of uncompensated work and distractors. Remember, check out those TED Talks I told you about. Start with why and drive. Okay, check those out. Number 2, budget no more than 20% overall effort for uncompensated work. The effort varies per week's on and off service and clinical days, so be mindful of that. Not every week is the same. Number 3 is protect your non-clinical time. I would suggest you set formal office hours. Now, there are a lot of people here who are academic doctors or on the VCU faculty role here. You know, it's not too long I've been doing this, about 3 or 4 years or so, but I saw somewhere like, I remember that professors when I was in college had office hours. Do you remember that, Fadi? So I said, okay, very well. I have office hours also. And why is that important? Because now every request I want to meet with Gonzalo, it says, those are his office hours. And those who are really serious about meeting you will show up for your office hours, either virtually or in person. So I found that was very helpful. Now, you have to be a little flexible. If my boss, Dr. Simon, calls to talk to me, I don't say my office hours are Tuesday. That's probably not politically correct. I'll say, yes, sir. Yes, madam, I will be right there. I drop everything, right? Like we should be doing for the boss, et cetera, et cetera. So set office hours that generally works. Minimize distractors like email, epic chat, epic messages. I'm telling you, those things are eating away at your time. And I ask my faculty members, if you made yourself maybe 20%, 10% more efficient, so that you got back 45 minutes to an hour a day, would you rather spend that hour here, or would you rather go home to your families? You guys think about that. Okay. Number 5 is prioritize both an individual and a collective response to the organizational uncompensated tasks. Remember, it's not everyone out for themselves. You have to be part of the team effort. So develop a plan for fulfilling potentially high value organizational tasks. We in infectious disease have one. Thank you, Dr. Rabel. That's our EVUs. Okay. And then number 6 is call your sponsor when tempted. You know, to fall off the wagon, is that what they say? If they're tempted to take on more uncompensated work, really consider calling your sponsor or sponsors to have a balanced discussion about the pros and the cons of what you're planning on doing. So after this discussion, what commitment to change do you have? What is the one thing you would want to start doing? Think about it. What is the one thing you want to continue doing? Like, I'm not giving that up. That's high value. That's really important to me. What is the one thing you want to stop doing that you could stop immediately or soon? And how can we hold each other accountable? Call each other out when we're doing things that are really, that may not be the best use of your time. Being polite about it, of course, but may not be the best use of your time. So for further reading, this entire presentation is actually a published manuscript. It's published in Clinical Infectious Disease, titled Minimizing Low-Value Uncompensated Work. So you're welcome to look into that. If you want a copy, you can certainly reach out to me and I will forward it to you. My acknowledgements, and before I get to that, I want to quote Mahatma Gandhi. It is Diwali, correct? So it's kind of appropriate, Mahatma Gandhi. So a no uttered from conviction or from the deepest conviction is better than a yes uttered merely to please, or worse, to avoid trouble. So really be thoughtful what you say yes to and no to. And remember, this is not necessarily something that you're doing exclusively for yourself, but it can be done for yourself and for the team, and it can certainly further your academic and professional growth. So my acknowledgements are to Dr. Priya Nori, is a co-author on various manuscripts with me. She's also the deputy editor or the second in charge editor of the journal that I edit. Peggy Andrews Depew, our executive assistant, and Rebecca Mullen for all her assistance over the years with many of these presentations, review of slides, and feedback on manuscripts. I think that's it. So we have a couple minutes, right? 10 minutes.
Any questions from the audience?
Thank you so much, Dr. Bearman, for this amazing talk. My question is, in your opinion, does compensation exist in any other form other than getting paid? And the genesis of my question is, I've heard once that sometimes compensation can come in the form of protected time to do a certain task or certain activity. So are there any other compensations within the context of big academic centers that can exist for people when they take additional tasks?
Yeah, so you're asking about different models of compensation within academic centers for additional tasks. Is that right? I have to repeat that for people online. So the ideal situation is you take a directorship of something, they give you a chunk of money and buy your time. That's the ideal situation. Others in which you're serving a function that is considered valuable but may not have a price tag to it, you can negotiate. And I would argue, by the way, if you don't negotiate, you're already taking, shot yourself in the foot. Okay? So if we're say want to create a associate director of such and such and have a clear mission as to what this person is going to do, we say this person needs 10% effort to do that. Therefore, we will take away 10% for clinical time. That's like one less clinic session a week to really take care of this program or this project or whatever role that she's doing so that they have protected time to do it and are not stressed out about it, may not gain financially from it, but are not adding extra work to the already very high workload, if that makes sense. It takes negotiation, but you got to be able to persuade. Okay. So to follow up on that, I think Dr. Dow may have a question. If you're going to persuade, you have to be very clear on the intent. Like, what are you trying to promote or do? That's number one. Number two is you have to be very clear on the ask. This is what I'm asking. If you're fumbling through your ask, you're not going too far. Number three, you have to know what's in the interest of the person you're asking, right? You have to speak the with them. You know what that is? Or what's in it for me? So if you have to be speaking what's in it for me or what's in it for them, so they understand why it's important. And this is the most common mistake after all that happens, is you fail to get a commitment to take the next step. So it's got to be able to persuade. And that's how you get these adjustments. Sir.
So good news is I hear this works online, so you won't have to repeat the question.
Awesome.
And I'll try to be thoughtful about this because I want to present a contrasting perspective that I don't think is conflicting, but just I'm curious about your thoughts. And that's sort of in defense of dabbling. I talk a lot about with our junior faculty, sometimes the residents, about this idea of like, well, try things and see what you like and figure out what you like. Whereas you and I, we're far enough along in our careers that we're pretty sure what we like and what we don't like. And so how do you think about dabbling in helping junior faculty who may not be quite as sure as to what they want to be doing 20 years from now?
I think dabbling is a great idea, but you have to dabble deliberately. Don't dabble in 10 things when you only have time to dabble in 2. Think about what's worth dabbling in at this time. And then ask yourself, if I've done this for a year and I'm not getting any joy out of it, I'm not learning new things, move on to something else. I think we both know that changing careers or changing focus during a career is not a tragedy at all. I think it's great. And let me be very clear, the things that I write that are low value are simply from the perspective of like when people tick off for promotion and tenure. Doesn't necessarily mean it's not worth doing. I've done morning reports years back. It's an important thing to do. But if you're going to do 50 of them in a year, that's too much. Be deliberate, do 1 a quarter, or do 1 a year or 2 a year, something like that. Other questions?
Any other questions?
There's
Todd
a
and-
question in the chat.
I thought there was a question in the chat. Okay, I thought you said.
Any other questions? Or is there any online that we should be looking at? Let's take a look. Okay, I believe Wake Forest, Stephen Mayer, I believe Wake Forest defines and compensates EVU educational value units. Can VCU and the VA take a look at how Wake Forest is defining and paying for EVUs? Great idea. That's beyond my pay scale. So if someone has an answer to that, that'd be cool. I really try to focus on things that you or we can do and not so much the institution can do for us. Any other questions? All right. Well, thank you very much. Appreciate it.
Thank you. Thank you. Thank you. Thank you all for participating. Please join us next week for the State of the Department address that'll be hosted by Dr. Patricia Sine. Lunch will be provided in the lobby afterwards. Thank you.